Okay, welcome to a discussion with Dr. Richard O'Reilly, a professor emeritus of medicine of psychiatry at Western University in London, Ontario. He's going to talk about the status and failures of treatment for those with serious mental illnesses in Canada. I'm Marvin Ross and a board member of the Family Alliance on Severe Mental Illness, FASMI, and they are the sponsors of this video. In way of background, FASMI was born of an understanding that the family voice that once strongly advocated for those with psychotic illnesses in Canada has been drastically diminished in recent years. Our vision is that every Canadian living with a psychotic illness must have access to the health care and rehabilitative supports they need to treat their symptoms and optimize their ability to function in society. We strive to ensure that Canadians living with psychotic illnesses receive timely and effective treatment and rehabilitative supports to achieve their maximum recovery. To this end, there must be suitable and easily accessible clinical support services, a supportive legislative framework, and families must be included as key stakeholders in clinical care and in system design and oversight. Sadly, that is not the case today, as Dr. O'Reilly will explain. So welcome, Dr. O'Reilly.
Thank you,
And
Mr. Ross.
I guess my first comment or first question is you came to Canada in 1984. How have services for the severe mentally ill changed over the last 40 years?
So, Mr. Ross, I would say that the services have unfortunately deteriorated and deteriorated quite significantly over that period of time. So, when I first came, there were sufficient numbers of beds in the psychiatric units of general hospitals and in a few surviving psychiatric hospitals that we could provide a good service to people with severe mental illness. But gradually, those beds have been whittled away and they're clearly inadequate at the moment. And in some parts of the country are the numbers are continuing to decrease. And so that means that, as I think a lot of our listeners will know, that when somebody's admitted to a psychiatric unit nowadays, there's scarcely enough time to treat their acute symptoms like hallucinations and delusions to a level where the patient is free from symptoms before they have to be discharged. And there most certainly is inadequate time to allow for discharge planning, including placements in the community. And for that reason, many patients are discharged to homelessness.
Right.
So we're clearly in a crisis situation. And overall, when I look back at those 40 years, I see that when I came to Canada first, people were actually getting a better service than they are now.
Right. Um, so what sort of specialized services for people with SMI are we lacking in Canada?
Well, I would start again with the beds. I don't think we need to go back to the institutional era. Like nobody believes that, and that's certainly not what I'm advocating for, where people were admitted and spent, huge amount of time in hospital, some living their lives out in freestanding psychiatric hospitals. But we must have sufficient numbers of beds so that we can treat people with the most severe mental illnesses, treat them until they are safe, that they aren't at risk of misadventure when they're discharged, aren't at risk of suicide, and aren't at risk of harming others, which of course is not strangers, but more typically is relatives who are looking after the individuals. So we have to have sufficient numbers of beds. Then we need to have sufficient and appropriate services in the community to meet the needs of these patients. And we do have some assertive community treatment teams, but not nearly enough. And again, some parts of Canada, some provinces don't have assertive community treatment teams. And other provinces, and Ontario is a good example, has ACT services, Assertive Community Treatment or ACT services, but not nearly enough. So originally, we were promised twice the number of ACT teams as we have now in Ontario, and which we need in Ontario. Not
Right.
everyone needs that level of intense follow-up in the community. Many do, but not everybody does. So we need a range of other services, including multidisciplinary teams like ACTS that take on many more patients so that they patients don't need to be seen, for example, on a daily basis, can be seen once a week or so, but the patients have access to a psychiatrist, nursing staff, social work,
Hmm.
occupational therapy, etc. So
Right.
that's the second thing. Maybe if I just finish the third thing that's really missing is appropriate residential care.
Right.
So we need a range of places in the community for people with severe mental illness. Some people are going to be able to manage just fine in their own apartments. Others will manage in their own apartments, providing they've got qualified professionals looking in on them from time to time and troubleshooting problems as they arise. But other individuals are going to need to be in group home situations. And for some of the most severely affected people, they're going to need highly qualified staff like psychiatric nurses on a 24-hour basis.
Hmm.
And while we have some of those services, the one thing that we have not been prepared to look at, which we need, are uh, residential services for the most severely affected. And this would require not only 24-hour round the clock service, but it would require homes where people would adhere to a curfew. They wouldn't be at loose in the winter when it's minus 20 degrees or off at nights using drugs and
Hmm.
exacerbating their psychosis, etc. So a range of services with some very careful monitoring for the most severely ill patients.
Okay, well, that was a pretty comprehensive list. Is there anything else that's missing?
Well, I think if we started with that, we would go a long way to
Right.
solving the problems. I mean, I think, the listeners to this video will see the problems if they walk around any medium or large sized Canadian
Right.
city where people with untreated psychosis are in the streets, clearly symptomatic, hallucinating, shouting, and living rough and putting themselves and sometimes others at risk.
Yeah, and actually, you've just answered my next question. which was going to be, is the lack of services affecting the homeless crisis.
Well, we know it is. We know that about 20 to 25% of the homeless population in centers in North America, including Canada, are suffering from a psychotic illness, a primary
Mhm.
psychotic illness. So while addiction is the major cause of the homeless crisis, untreated psychosis in a recent systematic review of studies from North America makes up at least 20% and probably more of that population.
Right. Yeah. I've also read that a lot of people are discharged from hospital into homeless shelters. What's the impact of that?
Well, that's absolutely correct, Mr. Ross. And I'm not too sure what their initial thoughts of that will be. One of the advantages of being a bit older and at this stage of my career is that I have seen the trends, and I never saw somebody discharged to homelessness before approximately 1998. That's when it
Hmm.
really started. And when that happens, there was a lot of controversy. People were shocked, whereas now they just shrug. And this is happening on a daily basis. My own hospital does this regularly. Even I'm not as critical of the hospital services doing this because there just simply are not enough beds. However, I want to make it quite clear that I totally disagree with a single person with psychosis being discharged either to a homeless shelter or directly to the streets. People may say that, well, what's wrong with a homeless shelter? And of course, the answer to that is that homeless shelters are no place to send somebody with a psychotic illness.
Right.
Homeless shelters are rife with drugs, and every person discharged to a homeless shelter gets offered drugs.
Hmm.
And the folks that we're talking about who have got severe mental illness are extremely vulnerable and vulnerable to using drugs, sometimes in an attempt to deal with their own symptoms. And of course,
Right.
that's the worst way to go about it because it only exacerbates the symptoms. And if you're female and you're discharged to a homeless shelter, you are going to be approached by pimps trying to encourage those vulnerable women to get into the prostitution game. And of
Mhm.
course, many have. So this is a total disaster. It's a disgrace. We should stop it now.
Right. And if they're not induced into prostitution, they're likely to be raped.
Well, homeless shelters are scary places, and many people are using drugs. So sexual abuse,
Hmm.
of course, is a real risk there, and violent behavior more generally is a real risk, and on the streets too.
Yeah.
And we know this. We know that people who have untreated mental illness, they are actually much more likely to be victims of violent behavior than perpetrators.
Right. So would you suggest that we need more group homes?
I think we do need more group homes, absolutely. But I would emphasize the need for a range of services. So some group homes will not need to be intensively staffed. We could have caseworkers visiting during the day. And in fact,
Mhm.
my ACT team sort of ran a group home like that, where there was not 24-hour staff, but our staff were on sites every day and troubleshooting and keeping an eye on things, keeping an eye on the cleanliness, cleanliness in the kitchen, those sort of things.
Hmm.
But we clearly have individuals who are going to need 24-hour staff because they have crises in the middle of the nights. They may start wandering or getting agitated, etc. And as I've already said, at the top ends, we need to look at ways to provide real safety for people who are unable to look after themselves and have a tendency to wander. I mentioned wandering on winter nights, using drugs at nights, bringing people back into their homes, etc. So people
Hmm.
need that extra level of security, and we have to figure out some way of doing that.
Yeah, some people would suggest that at the top end of what you're saying sounds more like a hospital than a group home.
That is true. That is true. And in the past, many of the people in the large freestanding psychiatric hospitals actually needed that type of care. It wasn't provided very well. These institutions were underfunded.
Hmm.
They were large and impersonal. What I'm thinking about is a much smaller type of facility in the community with strong links to the community, maybe 15, maximum 25 beds, and comfortable facilities with people, each person having their own room, etc. So yes, it would have some aspects of the hospital system, such as round-the-clock nursing
Hmm.
care, but it would be not an institution. It would be set and it would be connected to the community.
Right. Now, a lot of the supportive housing agencies combine people with serious mental illness with people with substance abuse problems. And I've seen quite a few difficulties with that. Is that an appropriate approach?
I think it is not an appropriate approach. If I can take a step backward, Mr. Ross, there's probably some benefits in having addiction services and services for people with mental illness and more, less severe mental disorders under the same governance. But that doesn't mean that the services have to be combined. And when it comes to residential care, the needs of people with substance abuse, pure substance abuse, and those with mental illness, and particularly severe mental illness, are different. Now, for sure, we have some people with severe mental illness who abuse substances, and they may be suitable to be placed in a residential facility that also has people with addiction problems. But if you take somebody who's not abusing substances, but has psychotic illness, and you put them into a group home with people with severe addiction problems, that's just a recipe for disaster. They're again like the homeless shelters. Those individuals are going to end up being offered and sometimes pressured by drug dealers to use drugs, and is there often are behavioral disturbances in those facilities, residences that are for people with substance abuse. So, and that can be very disturbing to people who
Mhm.
have paranoia or, significant anxiety associated with their psychotic illness.
Right. Um, the other trend these days is something called housing first, where the theory is you put homeless people into a nice residence and you don't worry about their mental state. Just that if you give them a decent place to live and provide them with some services, all will be well.
Yes, well, I don't really know the literature on housing first for people with substance use disorders. Um, Certainly, there is some evidence that it's can be helpful, but when it comes to people with severe mental illness, placing them, giving them an apartment does not work if you don't treat the illness.
Hmm.
And I mean, I've seen this time and time again over my career. People being placed in apartments with untreated or poorly treated psychotic illness, and they hallucinate during the night and shout at the voices, keep their neighbors awake, or they interfere or actually threaten other people because of their delusions, and then they can end up getting evicted from that apartment.
Right.
Uh,
And they're
and
back on the
people
street.
are back on the street, and people with thought disorder, disorganized behavior, also they don't end up keeping their apartment well or looking after things, and again got at risk for eviction. And of course, it begs the question: why would we place somebody with a treatable mental illness in an apartment before we actually treat their illness? And
Hmm.
of course, again, this goes back to the issue of hospitalization, having enough beds and enough time to adequately treat people before before designing a good discharge plan and then implementing that plan. That
Hmm.
is tried and true, and that's what we should be doing.
Right. And that's a pretty bleak picture that you're painting. So, has anything improved in the last 40 years?
Well, there are things that have improved. And I think it's the balance of the system that's gone badly. So one thing we've already talked about are the assertive community treatment teams, and these have been a godsend to many patients and their families. These are so-called wraparound services.
Mhm.
They go to the person, they provide the service often in the person's home or other community settings. ACT staff will meet people for a coffee, talk about how their symptoms are going, etc. Nurses will go to patients' apartments or group homes if they're supporting people in group homes to deliver medication, to administer injections, etc. So this has been really a great innovation. The problem, again, just to emphasize it, we just do not have enough ACT teams.
Right.
That's one big plus in the last 30 years, really, in Ontario. ACT teams started coming online in the 1990s. I think the second big innovation has been first episode psychosis programs. So I think these are excellent services that brought a degree of standardization to the assessments and treatments of people who are starting, have a first episode psychosis. They've shortened the time to bring people into treatment because in the past there was often a lot of uncertainty about what was happening and who should take responsibility, etc. So first episode psychosis programs have been a great innovation. Um, Although I think it's a little bit overhyped, the so-called neuromedications have certainly made a difference. They absolutely provide an alternative to our limited medications in the past. So when I started when I started working in Ontario, we had a limited number of medications, most of which had the potential to produce neuroleptic side effects,
Hmm.
whereas the so-called atypical antipsychotic medications are much less likely to do that. Some of them, really rarely cause neurological side effects and provide an alternative. The reason I'm a little cautious about them is that many of them have weight gain and other aspects of metabolic syndrome, such as onset of diabetes, as
Hmm.
problems. So they bring their own problems. Some of the more recently added drugs seem to provide a good balance in things. Um, I would, in the sort of list of things that have happened in the last 40 years that are an improvement, also mention the return of an older drug, clozapine. So
Right.
when we
Yes.
started in working in Canada in 1984, clozapine was not available, and it basically became available again in 1990. So it had been taken off the market in the 1960s because of a very problematic side effects called agranulocytosis, which is basically the lack of white blood cells, leaving patients open to infection. This occurred in
Hmm.
about 1 in 100 patients. But we have found that with regular blood monitoring, the risk of serious harm from agranulocytosis has been markedly reduced. And clozapine was brought back because it is absolutely the most effective antipsychotic that we have available to us.
Hmm.
And it's particularly helpful in those patients who fail to respond to other
Right.
antipsychotic medications. So anybody who's has failed to respond to a couple of antipsychotic medications should be considered for clozapine, even though it has its own other side effects, not just the granulocytosis, it's got some other problematic side effects, but there is a extensive body of research showing that people do better when treated with clozapine.
Right. Um, Unfortunately, we're starting to run out of time. So let me just ask you a couple of quick questions. Do you think the Family Alliance on Severe Mental Illness as an organization can make change?
Well, obviously I do, Mr. Ross, because I volunteer my time to sit on the board of FASMI. And I do that because I believe that only families and the voice of family caregivers can turn the tide of this progressive deterioration in the services that I've seen over the last 40 years. And sadly, I would say that when I look to the future, I see no indication that that the deterioration is going to stop. So there's
Right.
been no slowing in the deterioration over the last number of years. But I do think that a strong family voice, a confident family voice, demanding the things that clearly need to be done, can make a difference. And in other venues, I have said that don't look to governments to make the changes that are needed because governments have had well, 60 years to do that. The promise to put in the services that people with severe mental illness need as they downsized and closed large psychiatric hospitals, but they failed to do that. They continue to fail to do that. The money that's come to mental health services has increasingly gone to serve people with less severe illness. And in no area of medicine do we ignore the people with the most severe mental illness. We make, sorry, with most severe illnesses, we make sure in cardiology or rheumatology that the people with the most severe problems get the service that they need. And I would also say, sadly, don't look to mental health professionals, particularly to psychiatrists, to solve this problem. Because again, we've had psychiatrists looking at the train wreck happening over the last 40 to 60 years and failing to prevent it. And part of the reason for that is psychiatry is a divided house. Um, I spent my life working with the severe mentally ill, but many of my colleagues never see somebody with a
Mhm.
psychosis. Many of my colleagues are working in office-based practice, counseling people who have problems of everyday life. I'm not saying that these people don't need counseling, but I don't think doctors, let alone highly trained specialists, need to be doing that. But these colleagues will fight tooth and nail to maintain that and maintain the cost and services and ignore what's needed for people with schizophrenia and other psychotic
Right.
illness.
Yeah.
So families really need to step forward to make a difference.
Okay. Well, thank you for answering these rather difficult questions, and thank the people for watching this. If people are interested in FASMI, our website is fasmi.ca, and we could always use volunteers, donations, what have you. Um, so please feel free to get in touch with us, and we will get back to you. And hopefully, we'll have another session in the near future with Dr. O'Reilly. So thank you very much for taking the time to talk to us today.
Thank you, Mr. Ross. It's been my pleasure.
Okay, thank you.